Hello, I'm Dr. Ted Delbridge, Executive Director at the Maryland Institute for Emergency Medical Services Systems, or MEMS. I'm going to spend the next 45 minutes providing an update about Maryland EMS. Of course, it would be difficult at this particular time to discuss EMS or any aspect of healthcare without mentioning the coronavirus and COVID-19, but I'll try to provide a general overview. A quick recap of 2019. In 2019, EMS answered more than 1.2 million calls for help in Maryland. 547,875 patients were transported by EMS to Maryland and nearby out-of-state hospitals and freestanding emergency departments. That was up 1.8% from 2018. In all, there were 100 destinations. 45, many of them out of state, received less than 1,000 patients. 41 receiving facilities received more than 5,000 patients. This is a graphical depiction of the distribution of patients received from EMS by hospital emergency departments and freestanding emergency facilities. As you can see on the left, the hospital to receive the most patients by EMS received just under 25,000. The busiest EMS hospitals in Maryland were Franklin Square, Baltimore Washington Medical Center, Anne Arundel Medical Center, Frederick Health Hospital, and St. Agnes Hospital. As you can see, many hospitals received just one or two patients. Thinking about this a different way is the proportion of ED patients that are made up by EMS patients. In other words, what proportion of a hospital's emergency department patients arrive by EMS? As you can see, the average across Maryland is 21%, meaning 79% of patients who arrived at the hospital emergency departments got there without using EMS services. Some hospitals, however, receive a substantial proportion of their patients by EMS. As you can see, Prince George's Hospital Center receives nearly 35% of its patients by EMS, followed by Johns Hopkins Bayview, Suburban Hospital, Franklin Square, Northwest, and so on. We continue to pay close attention to the EMS to ED transfer interval, or the time that is required for the emergency department personnel to accept responsibility for a patient delivered by EMS clinicians. One way of thinking about this is the median transfer interval, roughly the average. And we can think about this in terms of how busy the emergency department is in general. In other words, is there a difference between the ability of a larger emergency department that sees more patients to accommodate arriving EMS patients, as opposed to a smaller hospital that may see fewer patients? As you can see on this graphic depiction, on the y-axis on the left side of the chart is an annual ED census, the number of patients seen in the emergency department over the course of a year. And on the x-axis across the bottom are the number of minutes composing the median EMS to ED transfer interval. And as you can see, there's little correlation between the busyness or the number of patients an emergency department sees and the ability to reduce the EMS to ED transfer interval. A different way of thinking about this is the 90th percentile transfer interval, or how well a hospital can affect transfer of a patient from EMS personnel to its emergency department personnel 90% of the time. It's a measure of reliability of the process. We think about the 90th percentile transfer interval to allow for the potential that 10% of cases represent an anomaly, an outlier. Perhaps the time wasn't documented well. Perhaps conditions in the emergency department were just truly exceptional. As you can see, again, on the left side of the graph is the annual ED census. And on the bottom of the graph is the 90th percentile EMS to ED transfer interval. Again, you can see that busier hospitals are not necessarily better or worse, nor are less busy hospitals. In fact, one of the busiest hospitals in the state sees nearly 90,000 patients a year. and yet has one of the lower EMS to ED transfer intervals at the 90th percentile. And a hospital that is much less busy has the longest EMS to ED transfer interval. The significance of that is that at least 1 in 10 EMS units that arrive at that particular hospital will wait at more than 80 minutes in order to transfer responsibility of the care of their patient from themselves to hospital emergency department personnel. We continue to work with hospitals to improve this situation. In fact, several hospitals have reached out to us in order to get more real-time data analysis and feedback so they can continuously work to improve their processes. I've shown this graphic before. It's a depiction of where we spend our effort. As you can see at the top of the inverted pyramid is the world of sick or hurt people. These people don't necessarily employ EMS. They don't necessarily go to the hospital. But we think about them in terms of our public education efforts and prevention efforts. The next section on the graphic is the population that engages pre-hospital or EMS care. We think about these people a lot. We certify and license EMTs and paramedics. We create protocols on how to care for them. We pursue quality improvement projects to make our care of them better. I'm going to skip the next section on the graphic and go to the bottom, the tip of the inverted pyramid. These represent the patients who need care at a trauma center or specialty referral center. We think about this limited population significantly. We create trauma centers, we create stroke centers, cardiac intervention centers, and others. We create quality improvement programs to monitor the care that we're providing. We strive to ensure that the right patient gets to the right place in the right time. And yet, this truly represents the vast minority of patients who need expert medical care. This is truly a limited population. But until recently, we haven't paid a great deal of attention to the bigger proportion of patients that seek care in a hospital emergency department. We pay attention to emergency department care in terms of base station designations, stroke center designations, cardiac intervention center designations, and trauma center regulations, all in terms of what's the emergency department contribution to the overall construction or implementation of a specialty center or trauma center designation. But we don't think too much about general emergency department care or the interface between the EMS system and the emergency department, except with regard to things like transfer intervals, which are important, but they don't describe the total need. Prior to the pandemic, we were able to convene a collaborative of hospital emergency services. These were hospital leaders, specifically focused on emergency services and emergency department care. And they came together here at MEMS to discuss best practices, to share information with one another, and to engage on important matters that were relevant to the emergency department EMS interface that occurs thousands of times each day. One of the things that we were able to talk about in that discussion was a concept we've called directed triage. It must be true that if a patient would be suitable to go to, for example, an urgent care center, or was of seriously low acuity, that instead of waiting at the ambulance entrance of the emergency department to go directly to a treatment area, that they could go into the queue of other patients arriving in the emergency department. And as we mentioned, 79% of all emergency department patients, on average, arrive by a means other than EMS. And so why would it not be appropriate for those patients who do come by EMS, who are of low acuity, to fall into the queue with other folks and be triaged more routinely by the hospital emergency department staff and essentially wait their appropriate turn? Well, we were able to engage hospital leaders in this discussion, and two jurisdictions, Anne Arundel County Fire Department and Montgomery County Fire and Rescue, pursued that approach in collaboration with their local hospital emergency departments. These two graphics represent the titles to evaluation reports that were produced by Anne Arundel County Fire Department and Montgomery County Fire and Rescue, describing their experiences in the early goings-ons. And what they found out was that lower acuity patients who they took to the emergency department were oftentimes appropriate for delivery to the waiting room for the regular triage nurse to evaluate. They found out that there were no adverse patient outcomes. They discovered that their units were able to return to service much sooner than if they waited in the queue waiting for the patient to be assigned a treatment area within the emergency department. And hospital emergency department staff appreciated the work EMS was doing to help them sort out the seriously sick and injured patients who needed immediate attention and those who didn't. We were also able to talk to the collaborative about chats, or the hospital alert system. This represents a particularly bad day last April, where many of the hospitals in Region 3 were on yellow, red alert, and reroute. We've been fortunate during the COVID-19 pandemic that hospital emergency departments were running at a fraction of their typical census as patients sought care elsewhere or deferred care altogether. But as the pandemic winds down, we can be assured that hospital emergency departments will once again be as busy as they ever were, and that chats will become a fact of our existence until we change it to be something else. We were able to talk to the Hospital Emergency Services Collaborative about different options. One of the things that we were able to convey is that going on yellow alert doesn't really accomplish what most people expect that it might. It turns out that a hospital in yellow alert receives about 0.12 patients per hour less than if they're on no alert at all. In other words, a hospital would have to be on yellow alert for more than 8 hours in order to not receive one patient that it might otherwise have received. This is a depiction of one of the EMS regions in the state. The green line represents the times when the hospital is on no alert, and the yellow line when they're yellow alert. And you can see the number of patients that arrive per hour, given any hour of the day, over the course of time, comparing when the hospital was on yellow alert at that time of day and when it was on no alert. And this is similar to what has been pointed out for years within the Maryland EMS system. Well, we intend to capitalize on our existing relationship with CRISP, the Chesapeake Regional Information System for our patients, to develop a new advisory system that doesn't require human analysis of emergency department status, interpretation of rules, and intend to put the hospital in some sort of alert status, and then the necessity of EMS personnel to interpret exactly what that means. We're fortunate in Maryland that now every single county and EMS jurisdiction makes its patient records available to the Chesapeake Regional Information System for our patients. As far as I know, we are the only state in the country where the entirety of the EMS system ensures that every EMS patient encounter is recorded and becomes part of the patient's permanent health record. It is really quite an accomplishment, but it has helped us develop an incredible relationship with CRISP to do important work throughout the state. One of those things we hope will be a new emergency department advisory system that is based on ED patient census, where it is possible for us to monitor in real time the goings-ons at hospital emergency departments and freestanding emergency facilities, so that without any human intervention whatsoever, we can assess the busyness of a hospital emergency department and in some way convey that to the field, so that EMS clinicians in the field can make an appropriate decision for their particular patient about where the best place to seek additional care is. We look forward to rolling this out sometime this year. The hope had been earlier this year, but we were a smidgen delayed or derailed by the COVID-19 pandemic. Another effort that we're undertaking to do similar work is the at-hospital ambulance dashboard, which we hope will provide EMS clinicians additional real-time awareness of the EMS-ED interface. and for EMS clinicians in the field, provide a wider angle perspective so that they can tell what's going on at the hospital that they contemplate going to, not only in terms of what EMS units from their own jurisdiction might be there, but what EMS units from another jurisdiction are also at that hospital, to give one more indication of how busy the emergency department actually is and where they may or may not encounter delays as they deliver their particular patient. This is a screenshot of my desktop computer displaying the Odd Hospital ambulance dashboard. And as you can see, at this particular moment, there were 32 EMS units currently staged at 18 different hospitals around the state, or at least the ones where we can see the jurisdiction's activity, and I'll explain that further in a minute. If we look at Frederick Health Hospital, you can see there are 4 EMS units there. The most recent one arrived 10 minutes ago, and the one that's been there the longest arrived 13 minutes ago. That's an important consideration. If going to Frederick Health Hospital was something that you were contemplating as an EMS clinician, you might realize that within a short span of time, 4 EMS units all arrived there. You might anticipate that Frederick is a bit busy at the moment. You might also look at Baltimore Washington Medical Center. Not that you would be contemplating going to either one of those 2 places at the same time. But if you were to look at Baltimore Washington Medical Center, you'd see that there are 7 units there. The most recent one arrived 10 minutes ago, and the longest one's been there for 61 minutes, and so on. Furthermore, if you were to look at Baltimore Washington Medical Center merely by clicking on it, you might see that 5 of those units came from Anne Arundel County, which you might expect, and 2 of those units came from Howard County, or 1 from Baltimore County. And so you get a feel for what's going on at the hospital, not just related to your own EMS jurisdiction's activity there, but others, which is a limitation in the current system as it exists right now. This is what it might look like on your smartphone. This is actually a screenshot of my smartphone in a beta test mode. And I can see that Sinai Hospital currently has 3 EMS units that have been there for quite some time. And if I was contemplating going to Sinai Hospital, I might want to think about how long those units have been there and how soon my patient is likely to get care, or how long I'm going to wait in a queue once I arrive. You can also see the current alert status is displayed, which as we develop a new ED advisory system will change. But again, the idea is to put as much information in the hands of EMTs and paramedics in the field so they can make appropriate decisions for themselves and the patient they are caring for. Our goal is for every county's EMS system to participate in the at-hospital ambulance dashboard. The green counties and jurisdictions displayed here currently do so. The limitation is how we receive the CAD file through ImageTrend and then are able to convert it into usable information that we can display as I've shown. Every county is working on a plan to make its CAD file usable for this purpose. As I understand it, the next to come online is likely to be Garrett County. But as we develop a critical mass of counties participating, we'll begin to roll this out to the field within the next coming weeks to months. We're currently conducting pilot studies in a couple of jurisdictions to get feedback. And our expectation is as we roll this out, we'll receive quite a bit of feedback from the field in order to make the product better and the most possible useful to EMTs and paramedics in the field. The whole goal is to help EMTs and paramedics understand where and when is the right place to go for themselves and the patient they are caring for. We continue to pay close attention to EMS naloxone administration throughout Maryland. Many of you may have participated in a webinar that was recently held to discuss best opioid practices within the EMS system. We discussed this at great lengths during that webinar. But to provide a quick overview, the blue line on the bottom represents naloxone administration by EMS in 2015 on a monthly basis. I personally think of that as our baseline. And since then, you can see how EMS naloxone administration has increased dramatically. And this isn't just EMS naloxone administration by EMS clinicians. In other words, if EMS clinicians document on the EMEDS report that naloxone was administered before their arrival by a bystander or law enforcement, for example, it is captured in this graphic. This is an important consideration because it is how we and many others are keeping track of the ongoing opioid pandemic and our progress in addressing it. And you can see that beyond 2015, for the additional years, naloxone administration by EMS was definitely up over the course of time. Toward the end of 2019, naloxone administration by EMS had actually decreased and was approximating 2015 numbers, which was good news. Although the opioid fatality rate in Maryland didn't improve as much as the EMS administration of naloxone did. So we continue to evaluate that. In the first part of this year, represented by the light green line at the bottom, you can see that we were continuing to approximate 2015 administration rates. That is until recently when we saw an uptick, represented by the red arrow. We continue to watch this and hope that the uptick is an anomaly. But the information that we glean from this, which is a result of your documentation on EMEDS reports, gets distributed and disseminated and considered widely by others who are addressing the opioid epidemic. One manifestation of that is ODMAP, which is a project of the high intensity drug trafficking area effort in the Washington, D.C. Baltimore corridor. In almost real time, EMEDS reports that indicate that naloxone was administered are uploaded into ODMAP, creating a cluster graph that can be analyzed by law enforcement to determine if there is, for example, a new distribution chain of opioid drugs in the community, a place where interdiction or further surveillance might be warranted. The extent to which EMS data is used to provide information in this regard and many other public health initiatives raises the stature of EMS in terms of medical care, public health, and public safety, and is a great testament to the work that is ongoing throughout Maryland. I alluded briefly to the alternative destination protocol when we were discussing directed triage. The question is, in that case, if a patient is suitable for going to an alternative destination, ought they not be suitable for going to the waiting room at the hospital emergency department? The alternative destination protocol was created in 2019 during the summertime, and a few jurisdictions have tried to put it into play by forging relationships with urgent care centers in their jurisdictions and prepare systems and processes so that low acuity patients could be taken there to those places instead of to hospital emergency departments. Part of creating the alternative destination protocol was to fertilize the ground for EMS jurisdictions to participate in ET3, Evaluation, Triage, Treatment, and Transport, which is a CMS 5-year innovation program to expand EMS reimbursement and to begin to reimburse EMS for transportation to a non-ED destination, which CMS, Medicare, currently does not, or when treatment is provided by a qualified health practitioner and no transport occurs at all. And currently, EMS is not reimbursed for that either. This connotes a telehealth connection so that the patient in the field can connect with a qualified healthcare practitioner and receive definitive treatment in the field without ever going to the hospital or an urgent care center. Well, several jurisdictions in Maryland applied to be ET3 participants. 4 Maryland EMS jurisdictions qualified and were notified that they were selected, and they include Annapolis, the city of Baltimore, Charles County, and Montgomery County. Each has a little bit of a different focus in terms of what they will do for the ET3 project. They all hope to kick off sometime this fall, and the goal at MEMS is to make sure the ground is fertile so they can be successful on behalf of all the EMS jurisdictions in the state and reach conclusions in their projects that will benefit everyone. I'll switch gears a little bit and talk just some about the COVID-19 pandemic, what happened in terms of EMS, and what we did here at MEMS to make sure that the EMS perspective was included in the state's response to the pandemic. An average day in Maryland includes approximately 1,500 EMS transports to the hospital. And as you can see, that was the case in the early part of the year until the beginning of March, when the pandemic began to evolve in Maryland, at which time EMS volume dropped off dramatically, and actually at its nadir was at approximately 50 to 60% of what it is on any given day. The same was true of commercial ambulance service activity. On a typical day, commercial ambulance service activity includes somewhere between 600 and 800 patient transports. At its nadir, it had dropped to less than half of that. Beginning on March 15th, EMS clinicians were able to document that the patient they were taking care of was suspected to be a PUI. And you can see from March 15th to the beginning of May, the number of PUIs encountered by EMS and subsequently taken to the hospital increased dramatically. And at its peak was just below 400 patients per day, which truly represented almost half of the EMS encounters during that period of time. This is what it's looked like over the past couple of weeks. And compared to almost 400 PUIs patients per day, EMS is now taking care of less than 200 on a running basis. And EMS volume in total has begun to approximate its routine. It's still not back to the 1,500 cases per day, but quite frankly, that might not be a bad thing. And it's possible that lower acuity patients are seeking alternative means for their care and/or transportation. The same is true of commercial ambulance services. The dips in the middle there represent the cadence of commercial ambulance service activity with hospital rhythms. In the early goings-ons of the pandemic, MEMS pursued a number of actions, some that I'll characterize as clinical actions and some as operations matters. In the early days, we suspended the preference for special pathogen receiving centers. You may recall that special pathogen receiving centers were a result of the Ebola scare several years ago. The idea being that hospitals could be better prepared to take care of highly contagious patients if we selected a few. What was clear in terms of coronavirus is that the mode of transmission was much different. Additionally, there were many more patients, and it soon became obvious that the preference for special pathogen receiving centers was not practical throughout the state. Secondly, we developed a viral pandemic triage protocol, which I'll show you in a minute. The viral pandemic triage protocol was intended to help EMS clinicians identify patients in the field who were appropriate for self-management at home, and likewise for helping them determine which patients ought to go to the hospital for further care or evaluation. The viral pandemic triage protocol was immediately noticed by several state EMS systems and adopted for their use throughout the country. It was the subject of an article in the Journal of Emergency Medical Services several weeks ago. We authorized use of terbutaline as a beta agonist in cases of bronchospasm. The goal was to limit the aerosolization of respiratory secretions that might result as the use of albuterol in patients who were experiencing bronchospasm who might be contagious with coronavirus. We provided specific guidance to 911 centers. We wanted to ensure that 911 centers were able to appropriately query callers to help identify PUIs in advance of EMS personnel arrival at the scene so that they might have the opportunity to be donned in appropriate PPE before encountering a contagious patient. We also wanted to provide guidance to not instruct callers to perform mouth-to-mouth resuscitation where that might otherwise be indicated. This is the viral pandemic triage protocol. The idea is that if all these questions are asked and all the check marks fall in the clear boxes, the patient might be appropriate to stay at home and self-manage him or herself. Of course, the EMS clinician in consultation with our patient is always the final word. If a check mark landed in a shaded box, the guidance was that those patients might be most appropriate to be further evaluated at a hospital emergency department, and transportation should be encouraged. One of the other jobs at MEMS since the early days of the pandemic was to monitor the entire healthcare system status. And we create daily dashboards to do that. Here's an example of two of them, the first one on April 13th and the second one on May 11th, just to give you an idea of how things changed over time. We were interested in how many patients were in the hospital related to COVID-19, what the availability of bed space was in the hospital, and also what the availability was of critical supplies and equipment. For example, we know that ventilators are critically important in the management of COVID-19 patients. And so we began to keep track of the ventilators. And you can see on April 13th, there were 1,239 ventilators available in the state. On May 11th, there were 1,396. There were actually more patients in the hospital and more patients in the intensive care unit. However, by this time, the state had acquired a number of ventilators from all kinds of different sources, and we were putting them in the field. And not only did we know there were ventilators in the field, we also kept track of where in the system they were available. We've been keeping track of the number of patients in the hospital, and you can see that on April 13th, there were just under 1,100 patients, both in intensive care units and in adult acute care beds. By May 11th, that had risen to above 1,600. And we kept track of the number of beds available. The number of ICU beds never dipped below 150 available ICU beds throughout the state. But during this period of time, Maryland Department of Health was actively working with hospitals to expand bed space, and several hospitals redesigned their interior spaces to be able to care for more critical care patients. We continued to monitor the healthcare system, and we are watching the number of COVID-19 patients within the hospitals decrease, but there is ongoing concern for the next surge or a new wave of COVID-19 illness as the summer progresses and we move into fall. Therefore, we continue to monitor the situation, and Maryland Department of Health continues to work with hospitals to expand not only inpatient space, but their ability to accommodate an increased flux of emergency department patients as healthcare seeking behaviors return to more normal levels within the state and within the hospitals. It might not surprise you that the distribution of COVID-19 patients throughout the state was variable, as was the burden of hospitals to care for those patients. This is a depiction of the top 10 hospitals in the state and the number of COVID-19 patients they have taken care of to date. Leading the way is Holy Cross Hospital with 582 patients, followed by Johns Hopkins, Anne Arundel Medical Center, Doctors Community Hospital, and the University of Maryland Medical Center. It turns out that 25% of Maryland hospitals took care of more than 50% of COVID-19 patients throughout the state. We continue to be interested in what that meant for the EMS system. While it's true that the number of EMS cases decreased during the height of the pandemic, it is also true that the relative acuity of the patients they encountered seemed to increase as well. And while some of that is just a reflection of proportions, and the number of high acuity cases didn't increase in terms of absolute values, the number of cardiac arrests absolutely did. And you can see by the gray line on this here graph that the number of cardiac arrests during the weeks of the COVID-19 pandemic in Maryland increased by 25 to 30%. Similarly, the number of terminations of resuscitations increased as a proportion by nearly 10%, and the number of successful cardiac arrest resuscitations decreased. We continued to evaluate the significance of this, and it may not be the only clinical entity where there is a similar finding. Mid-March, we sought and received an executive order from the governor that was intended to help us augment the EMS workforce and improve the response to the state of the emergency. The executive order enabled us to suspend any provision of the education article, which defines MEMS and the EMS system, and of COMAR Title 30, the rules and regulations associated with the EMS system. We did a couple of things quickly. We revised the mobile integrated health staffing requirement to include just one paramedic, instead of requiring a nurse and a paramedic. Our intent was to beef up the ability of jurisdictions to provide MIH, and in some cases provide follow-up visits or telephone calls to patients who they had utilized the viral pandemic triage protocol, and make sure that their decision to leave a patient at home was a correct one. Since we had revised the MIH staffing requirement, we were able to authorize a new provisional MIH program, a collaboration between Kaiser and ProCare Ambulance. We developed an option to revise SCT personnel staffing requirements depending on a patient's need. For example, allowing the option for 2 critical care transport nurses to accompany a patient instead of requiring automatically that there be a paramedic. In theory, that might free up a paramedic to staff an additional unit. And finally, we authorized the use of out-of-state licensed vehicles by in-state ambulance services. The result is a commercial ambulance service that is licensed in Maryland, but has a vehicle that is also licensed in Washington, D.C., would be able to use the Washington, D.C. licensed vehicle within the state of Maryland. One of the neatest things that we were able to do was use the licensing apparatus of MEMS to credential clinical externs. Clinical externs are health sciences students who were willing to engage in operations of the healthcare system to respond to the pandemic. And the healthcare system was looking for people like this who had limited experiences but valued clinical experience that they could put to work. And so we collaborated with all the nursing schools in the state and all the respiratory care schools in the state to develop criteria for clinical externs who were nurses and clinical externs who were respiratory therapists. The nursing students were defined in one of 3 levels, and the schools, each as students applied, validated the experiences of the student and authorized them to be at level 1 through 3. Since the beginning, we've been able to credential 680 clinical nurse externs, with 124 still in the queue. And in the queue means that their schools have not yet validated their clinical experience. We've been able to credential 85 respiratory care clinical externs. They're designated in one of 2 levels as defined by their schools. These have been incredibly awesome experiences for these particular students. They have been employed by hospitals and other healthcare settings, at COVID-19 testing sites. We continue to get feedback from both the respiratory care and the nursing students that they are enjoying their assignments. They're getting real life clinical experience. They feel fulfilled and engaged in the response to the pandemic. And in many cases, their schools are providing them academic credit depending on the experiences they are garnering. More relevant to EMS clinicians, though, is how we responded to augment the EMS clinician workforce. The first thing is we extended re-licensure cycle by 6 months for paramedics and EMTs who should have expired at the end of April or the end of June. We recognize that several continuing education conferences were required to be canceled due to social distancing requirements, and that might limit the ability of folks to get the required continuing education they needed to recertify or re-license. So if you're a paramedic or an EMT that was set to expire in April or in June and you didn't re-up, your license or certification was automatically extended 6 months. so you'll now expire at the end of October or the end of December. We hope that those 6 months of additional time will allow people the opportunity to do what they needed to do to be able to re-license or certify. I think even more importantly are the numbers of people we've been able to credential as provisional clinicians. Provisional clinicians are people who we were able to credential on the basis of expedited reciprocity, on the basis of reinstating an expired person, or allowing a student to engage in the EMS workforce. We had heard from people they were attempting to reciprocate from another state. They were Maryland folks. They lived in Maryland, but they were currently active in a different state, and if they could just be reciprocated, they would be happy to be engaged in Maryland. We heard from EMTs and paramedics who had expired and let their certification or license lapsed, and they would tell us that, geez, I'm no longer an EMT because there was a hiccup when I was supposed to reinstate 3 years ago, but I'm still a member of a volunteer fire department. I would love to be helpful if only there was a way. And we heard from students who had gotten all the way to the end of their curriculum, but were unable to complete internships, field clinical experiences, or to take written examinations or psychomotor examinations because those just weren't available at the time. So in all, we were able to provisionally credential 277 people by expedited reciprocity, 458 people by reinstatement, and 231 students. And you can see there among them are 32 EMRs, 783 EMTs, 6 CRTs, and 149 paramedics. We understand that somewhere between 50 and 75% of these folks are active within the EMS system now. And many of them have begun to call us to find out what happens at the end of the declaration of emergency and how they can maintain their certification or license. So we, also interested in the same objective, began to think about how to do that. One of the important features is that we needed a process to begin within 30 days of the expiration of the governor's emergency declaration. Because, as the provisional EMS clinicians have pointed out, 30 days after the end of the declaration, which hasn't begun yet, they turn into a pumpkin. And so we proposed an emergency regulation back in May that would give us the latitude to convert provisional status to full certification or licensure. We received approval from the Joint Legislative Committee that does those things on June 1st, and we're now in the process of creating the guidance to provisional EMS clinicians on how they go about becoming permanent. The other thing is that we need a permanent regulation because the emergency regulation expires in 6 months as well, and so we need a permanent fix that we're currently working on and should be published for public comment here shortly. One of the challenges in creating a system to take provisional clinicians to fully certified or licensed clinicians are the many permutations that existed in terms of how people got to be provisional folks in the first place. It's not too difficult for students. They're basically all the same. But in terms of reciprocity, some people are nationally registered and some people aren't necessarily, depending on where they came from. In terms of reinstatement, some people were nationally registered at one time and some were never nationally registered. And there was variability in terms of how long people had been out. Some people had been uncredentialed for less than a year, in which case we already have regulations on how to get back into the system. Some people were out for 1 to 3 years with some degree of recency of experience, and some people were out longer than 3 years, which obviously meant less recent experience. We also considered the importance of being active during the emergency. We weren't really interested in credentialing provisional EMS clinicians who became provisional folks and weren't active or didn't engage during the course of the emergency. We also wanted to provide reasonable but not excessive time in order to accomplish whatever it was the requirements were. So we chose 180 days after the emergency was over. The exception to that are nationally registered provisional paramedics. People who are in the process of becoming nationally registered paramedics have until 2021 to complete the psychomotor exam according to the National Registry. And that is because of limitations of accessing those tests. So the variables we considered were EMS continuing education requirements, the necessity for protocol review, re-entry cognitive exam, and a re-entry psychomotor exam. And as I said, there are many permutations. I'll provide you just a couple of quick examples. If you are a provisional paramedic, you have 180 days after the emergency declaration ends to do the following. If you are a student, you must take the National Registry cognitive exam and a protocol review. And you have until December 31st, 2021 to take the National Registry psychomotor exam. If you became a provisional paramedic by way of reciprocity, you have to have non-provisional certification by the National Registry, and you have to complete a protocol review session approved by MEMS. If you became a provisional paramedic by way of reinstatement, you have to have been active in EMS service during the emergency. You have to have a non-provisional National Registry certification and protocol review session, or if you are in the queue to pass the National Registry cognitive exam within the 180 days, you have until December 31st, 2021 to pass the psychomotor exam. And also you must complete a protocol review session. Provisional EMT is probably the most complicated, and they're the most people. It's complicated because of the number of permutations somebody could have become a provisional EMT by. So within 180 days at the end of the emergency declaration, if you became a provisional EMT by way of reinstatement, if you were ever nationally registered, then you have to document affiliation with an MSFA during the emergency, in other words, be active, and you have to show that you have 24 hours of EMS continuing education within the past 12 months. So if you have none at this point, basically you have 180 days to get 24 hours of EMS continuing education. If you were never nationally registered and you were lapsed for 1 to 3 years, you have to document affiliation with an MSFA during the emergency. You have to show 24 hours of EMS continuing education within the past 12 months. And you have to take a cognitive reinstatement exam approved by MEMS, basically a MEMS test for reinstatement. We expect there to be a number of questions from the people that were provisionally certified as to what their requirements are, and we'll be prepared to answer those. And as I said, the guidance will be coming out shortly and referenceable on the MEMS website. And I realize this doesn't apply to many of the people who are enjoying this here presentation, but certainly you may know somebody and can help them out. And I'll conclude by talking quickly about Vision 30, or the Maryland EMS plan. It is the Maryland EMS plan that gives the EMS board its direction, its guidance, and helps MEMS chart its future course. Many of you were able to participate in the last Vision 2030 exercise, which was the Blue Ribbon Conference held in Annapolis on December 18, 2019. Since that time, the steering committee, its 6 members, have evaluated all the public comment that was received, incorporated the public comment and ideas into the EMS plan, which still exists in draft form. Over the next couple of weeks, the steering committee will be finalizing the plan, and within the next month or so, Vision 2030 will be available for public distribution. Again, Vision 2030 is the tool that gives the EMS board and MEMS its guidance and charts the vision for the future. It is not a checkbox list of things to do. It is the roadmap, the guide. It tells us where we're going to go, the exact route we take, and in what order and on what pace is truly up to us. It is for each of us to look inside the plan and find the piece that pertains to us and take action. And I hope that's what you'll do, and there'll be more to follow on this in the upcoming short time. I'll close by reminding you that I think about these things in terms of us being EMS clinicians. It is a distinction that is reserved. It has certain connotations of professionalism. and is a distinction that is deserved. And with that, I'll close. Thank you very much for your indulgence and your attention during this overview of EMS in the state of Maryland. I wish you well. Thank you.